Class is about neuromuscular disorder and intensivist role in it. What is a neuromuscular disorder? So it is a disease that affects the lower motor unit, which is responsible for voluntary movement. The motor unit consists of anterior horn cell, which is located in the spinal cord, peripheral nerve, neuromuscular junction, muscle fiber. If any part of this pathway is damaged, the muscle weakness results. So classification of neuromuscular disorders. Anterior horn cell disorders, examples are amyotrophic lateral sclerosis, spinomuscular atrophy, poliomyelitis, West Nile fever. Peripheral nerve disorders, which is pathologically differentiated into two types. One is demyelinating and axonal neuropathy. So demyelinating examples are Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, axonal neuropathy, diabetic neuropathy, toxic neuropathy, and critical illness polyneuropathy. Neuromuscular junction disorders. So it is classified into three types: postsynaptic, presynaptic, and toxin or drug induced. Postsynaptic example is myasthenia gravis. Presynaptic, Lambert-Eaton myasthenic syndrome and botulism. Toxin or drug induced aminoglycosides, magnesium, organophosphorus induced. Muscle disorders, muscular dystrophies, Duchenne muscular dystrophy, Becker's, inflammatory myopathies like polymyositis, dermatomyositis, and inclusion body myositis. Metabolic myopathies include glycogen storage disorder, mitochondrial myopathies, and toxic myopathies include steroid induced and statins. So, how a neuromuscular disease presents to the ICU? Uh, ICU admission is required whenever there is an acute respiratory failure, bulbar dysfunction, which is leading to an aspiration, rapidly progressive weakness, autonomic instability, cardiac involvement, rhabdomyolysis, metabolic crisis, and bulbar weaknesses include inability to cough out, swallow, or risk at aspirating orogastric secretions, impaired respiratory muscle function leading to respiratory failure.
Just to summarize this, basically, just go to the back slide. So the presentation to the ICU can be a direct presentation that you will get. You can get inpatients. So last few years, you can say last 5, 6 years, me, Praveen, Praveen Yadav particularly, we have fascination towards these. We have diagnosed so many inpatients myasthenias and inpatient DBS. Inpatient myasthenias are not very uncommon. Patient presenting with some other disorder, getting stuck up on the bed. And the most common thing, if you just try to summarize the presentation in the ICU, one thing will be the most common thing you will get is difficulty in breathing. Difficulty in breathing is a topic in itself. One of the major part now, as we are treating more and more complex disorders, are hospital-induced, disease-induced respiratory disease involvement, plus any patient who is chronically getting treated in the ICU will develop certain forms of respiratory involvement or muscle involvement, either due to the drugs, either due to the chronicity, either due to COS, or either due to evolution of any one of the syndromes. So, if you want to just summarize in one or two statements, what commonly that we will get is difficulty to breathe from the ventilator, acute onset respiratory failure, or difficulty to breathe will be the number one symptom that we will be involved in. Apart from that, generalized weakness or weakness in particular group of muscles. This can be there. That is a common thing that you will get. If you somebody who will be placed in ICU 2, you will get now last 2 to 3 months. We have covered so many of them. Basically, we got almost 7, 8 GBS, 3 myasthenia crisis. Then we have got viral myositis with underlying dermatomyositis, recently diagnosed. She is discharged. Another one where we have done some biopsy. Another one right now, Dr. A is managing right now is preclinical myopathy. A patient who is stuck up for a long time, tracheostomy, old chap with multiple bouts of sepsis, some amount of steroid received. So we have seen almost quite number of cases last 2 months, basically, almost covering GBS all ailments. In fact, one guy is stuck up for 2 months now with a refractory GBS. We are managing 2.5 months now. Okay, apart from that, 3 proper myasthenia. One is paraneoplastic myasthenia. One was limb also, Lambert-Eaton also. Then you have myositis, viral myositis with background of dermatitis. One patient with rhabdo. Again, one more patient with rhabdo, 5,000 of CPK, presenting with acute respiratory weakness, presenting with myasthenia, but because we are CPK should not be so high, we did a muscle biopsy also for that patient, and we still under monitoring. So almost this is a common thing. Also, you have patient. I think one of the patient you can see one got stuck up on the bed. Difficulty in breathing. Somebody was involved. Nothing was involved. Last month also. There was one or two cases I heard that there was difficulty in breathing. Difficulty in breathing. So these will be the most common things that you will get. See, you won't get a patient with autonomic instability. Suddenly autonomic instability happens, and you say that the patient will be having some sort of neuromuscular disorder. The most common thing definitely will be this only. Now, associated symptoms can be anything apart from that. That needs an evaluation. Okay. Next.
So patient assessment, first initially we have to initiate the resuscitation. Acute weakness may be the primary reason or secondary to an episode of critical illness. Immediate assessment of the patient's clinical condition, duration of the symptoms, airway breathing, the need for airway protection and the ventilatory support has to be assessed, and circulation we have to assess. The criteria that point toward the respiratory failure are tachypnea, variable respiratory pattern, paradoxical abdominal breathing with alveolar hypoventilation, carbon dioxide retention, inability to complete a sentence. Dyspnea might not be a predominant symptom. It can occur in the later stage. Impaired forced expiration, which is ineffective cough causing accumulation of secretion, and retention of secretion causing segmental collapse and ventilation perfusion mismatch. Bedside assessment that indicates the need for intubation or inability to count to 20 in a single breath, forced vital capacity of less than 15 ml per kg body weight, negative inspiratory pressure of less than minus 25 to minus 30 centimeter of water, arterial PaO2 of less than 70 mm Hg on room air, dysphagia with bulbar muscle involvement.
And both the this is not complete. With my experience is that article PO2 is important, article PCO2 is also important. Particularly in patients with GBS, you might have a very good patient sitting with a good SpO2, never get fooled by that. Always have a tendency to do your single bed counts, always have a tendency to do ABG, watch out for PCO2. Early PCO2 rise with a borderline single bed counts can be an independent marker to go for intubation patients. So don't get fooled by SpO2. Sometimes when you are giving good amount of face mask O2, you tend to get a good saturation on the monitor. Never get fooled by that. Never give too much of oxygen also to a patient with GBS because you will get fooled by the same patient. Always do PO2, middle of the night, or in critical time zones in which your monitoring is low. You always do PO2 and ABGs. Whenever you see that PCO2 is going up, that can be a reasonable marker of your respiratory disorder, and that those patients might need just for that. Okay. So I think that one is the that is my experience that I have seen. PCO2 should also be
Yes. Neurological assessment, history of presenting complaints, preceding illness or immunization and other comorbidities. Detailed examination helps in pointing towards a diagnosis. Specific therapy then may be given. First step is to decide whether it is an upper motor neuron or lower motor neuron lesion. Further anatomic localization along the neuraxis can then be done depending upon the specific features. So difference between the upper and the lower motor lesions. So upper motor lesion occurs in the brain or spinal cord. Lower motor neuron occurs anyway in the anterior horn cells, roots or plexus, nerves, neuromuscular junction or muscles. So upper motor neuron has weakness which is pyramidal distribution, and the extensor muscles in the upper limb are involved, and flexors of the lower limb will be involved. Spasticity, brisk reflexes, clonus, extensor plantar without muscle wasting, and in acute cases it may be due to cerebral or spinal insult which presents as flaccid weakness and areflexia. In cerebral lesions there may be altered sensorium, seizures and hemiparesis. Brainstem lesions present as craniopathies with crossed hemiparesis. In lower motor neuron lesions there will be muscle wasting, fasciculations, hypotonia, diminished or absent reflexes. uh, so in anterior horn cell disease, there will be weakness present and wasting which may be patchy, and the most prominent feature will be the muscle fasciculation, and there won't be any sensory involvement. In root or plexus lesion, the lesion may be painful, asymmetrical, involving the corresponding myotomes and dermatomes. Lesions of the peripheral nerves will be symmetrical. Usually, distal weakness will be present with the Gloven-Stocking sensory loss, and there is distal reflexes will be absent. In neuromuscular junction, there will be true fatigability, which is the most prominent feature, and ptosis, eye movement abnormalities, difficulty in chewing, faciobulbar weakness, proximal limb weakness, absence of any sensory involvement. In myopathies, the lesion will be symmetrical. Usually, proximal muscle weakness will be present, which is the most prominent feature, and deep tendon reflexes will be present. Muscle wasting will be absent until the later stages of the disease, and there won't be any sensory involvement.
So this is a bit complex, but we can simplify this into a very simple loop in which whenever you get these patients, so I'll just start from the top to bottom, basically. So first will be your brain, definitely. So any sort of reduced sensoriness, any patient presenting with a generalized weakness or so brain, your how is the sensorium of the patient? That will be the number one thing. Then predominantly motor involvement or sensory involvement. So classify that, whether it is motor or sensory. Okay, you see, okay, sensory there is no sensory involvement. If it is pure motor, whether it is symmetrical or asymmetrical. So this is the rough classification you can do. To jot down, sometimes there might not be a single diagnosis. Your purpose is not to get the diagnosis. Your purpose is to classify the syndrome, whether it belongs to. Now, in that syndrome, it can be two or three entities together. A GBS can be present in all the areas because GBS has so many variants. A myasthenia can have overlap. Sometimes there are overlap. There is very difficult to distinguish between myasthenia and limbs sometimes. So sometimes, but it is easy to at least say that it is neuromuscular. So now, if you classify that, brain definitely comes top of the things, whether your patient sensorium is good or not, then background history of any drug injection, chronicity, chronic sepsis, steroids, all those things will come into the mind. Second will be your motor. I told you, first is brain, then motor, pure motor, motor with sensory. If it is motor, it is symmetrical, asymmetrical. Then second will be your ECG, peripheral nerve stimulus, whether reflexes are there or not. If the reflexes are there or not, whether the muscle hooks are proximally symmetrically involved or distally symmetrically or asymmetrically involved. So that will classify your disease into the subheadings, major subheadings. Neuromuscular fatigability. The most common thing will be progressive fatigability. Patient is looking good, but progressively, sometimes he is good, some times of the day he looks very fatigued, then again he is good. So that kind of maximum meaning is neuromuscular. Myopathies will be very symmetrical, proximal, distal lobes involvement. Uncommon, we won't find, we do get it, I'm not telling you, but usually when on that, keep it down the list, basically. The most common will be the acquired things that is to be topmost concern to us. So in that way, this is the major classification that we get. Where the sensorium, motor, sensory, motor sensory, fatigability, and your reflexes. So if the areflexia is there, you can easily say that it might be involvement of the peripheral areflexia. Reflexes are present, then definitely you have to think that it is not related to the peripheral nerves. It is. So likewise, if you classify according to the symptoms early on, then you know that my patient belongs to this syndrome. These are the symptoms, these are the probabilities that I am dealing with this. Next.
So neuromuscular pathology in critically ill patient develops in two settings. One will be primary neurological diseases that require admission to the ICU for close monitoring or mechanical ventilation. Examples GBS, myasthenia gravis, anterior horn disease. And the second one is critical illness polyneuropathy and myopathy, where it is acquired during the hospitalization. So GBS and critical illness neuropathy or myopathy may be difficult to differentiate from each other as they have an acute presentation. In case of GBS, facial and bulbar muscles are involved. The autonomic nervous system, there will be dysautonomia, and in CSF finding there will be albuminocytological dissociation, which may not be the case in critical illness myoneuropathy. In GBS, acute demyelinating neuropathy, though axonal variants can also occur, and in critical illness myoneuropathy, there will be only axonal type. GBS functional prognosis is quite good in CIMN. and they resolve very slowly over weeks or months with the possibility of a significant residual deficit after 2 years also. So investigations that has to be sent when the muscle pathology is suspected: serum potassium, calcium, vitamin D levels, and creatine phosphokinase. If the diseases of the peripheral nerves, blood sugar levels, renal and liver function test, vitamin B12 levels, and serum protein electrophoresis. In case of both the neuropathies and myopathies, thyroid function test, HIV serology, vasculitic markers, and paraneoplastic antibodies. In myasthenia gravis, anti-acetylcholine receptor antibodies is a sensitive test. So imaging wise, it is required in case of suspected CNS disease, CT brain. Electromyogram and nerve conduction velocity studies are required to diagnose the nerve and the muscle disease. And demyelinating neuropathy, the distal latencies are prolonged with a dispersed compound muscle action potential, and conduction block and the nerve conduction velocity will be decreased due to the absence of the damage to the myelin sheath. In axonal neuropathy, due to the damage to the axons, the amplitude of the action potential in the nerve conduction studies will be decreased. In electromyography, the fibrillation potential and the positive sharp waves with the decreased recruitment will be present.
Investigations will be closely linked to what your initial diagnosis is. First, you have seen hypersensitivity, motor sensitivity, because you have classified in your test, seen the patient, that which group of patient belongs to. Before that, there is a history. What is the background history? How chronic my patient is, whether it is acute or chronic. That is important. Better always have a habit of looking into the drug chart. What are the drugs doing? Chronic neuromuscular blockade enemies and steroids are number one pathogenic reasons in the ICU in which the patient can suffer. Enemies can cause anything, starting from motor weakness, your energy involvement, particularly chronic enemies can cause delayed discharges, it can cause energy disorders, looking very similar to many of the pathologies. So energy is one of the causes in which you should have an active effort that if neuromuscular blockade is really not required in the ICU, we should cut short of it. So mechanisms also, if you really do biopsy of all these patients who go LMD for a very long time, say patients who are on ARDS, you tend to give them 4 to 5 days, 6 days of LMD. You have to be very careful with these patients. These patients, you have to be very, very cautious and start early physios, because these patients will be very, very high on the risk of going into myopathy. So in these patients, very, very important is to know the drug history. That is important. Electrolytes, very, very important. Vitamin D levels are important, but they cannot be only the factor that can go into. When doing a early CPK, very, very important to really see whether the CPK is raised or not. Your myopathy CPK is going to be on the higher side. If you are suspecting a bit of LMJ or other disorders, you won't see CPKs on the higher side. So this is one of the workup that we do. Blood sugar levels are extremely important, particularly what correlation you get with if you are suspecting polyneuropathy, say critical care reduced polyradicular neuropathy. So one of the associated things that they say is if your blood sugar levels have been uncontrolled for a long time in a critical care patients, that is a direct correlation with developing not myopathy, polyneuropathy. Critical care, there are two elements to it. Critical care polyneuropathy, critical care myopathy. Okay, so polyneuropathies in critical care, reduced, one of the factors is poor control of blood sugar, or the blood sugar average is on the higher side. You will see most patients going into polyneuropathies more likely. So a set of investigations apart from the serum electrolytes, background history, sugar levels, B12, vitamin D, though we do send, but okay, they can be associated factors. They very rarely we see that they are the primary factors of causing so much of high, but they can be associated factors. Okay. Then yeah, next. So this, when you have done that, and you have a clinical, now you have a clinical suspicion. You have classified your patient, you have sent your labs, you have got something in the labs. Now you need to really know, classify these patients for reach to a particular diagnosis. Okay, in those cases, you are electro EMG will help, electrophysiological studies will help only in those scenarios. But only limiting factor is that you in acute scenarios it is difficult to discriminate. Right. So if you do a nerve conduction very early on in a GBS, you might not get you, so you might have to repeat sometimes. So you ideally do in the acute scenario or day 1, day 2 when you are missing, you have to repeat it after 4 to 5 days. Okay. Sometimes it is very difficult to only discriminate based on NCS. It looks very nice when you read in the books that you do NCS, you do RS, and it classifies. It is so nice. Everything. Sometimes if you most of the NCS that you do, 50% of them will be not conclusive. You will not draw any conclusion out of them. The CMAP thing that you see gradually increasing CMAPs, that can be a common symptom in many of the disorders. So how will you classify it just on based on one aspect? And particularly a patient who is chronically in the ICU or in the hospital, you might have multiple elements playing together. There might be element of polyneuropathies, there might be element of NLVs, there might be element of chronic steroid, sepsis, electrolytes, all playing together. So your NCS or the energy will be very, very confusing. So it might not tell you the correct picture, but it is part of the classification. As you go now, this will definitely help you in further streamlining. You have 3 DDs now. In further streamlining, it most likely looks into it further helps you to jot down into the time. Next.
So in myopathies, there will be small amplitudes, short duration, polyphasic action potentials are seen on the electromyography with rapid recruitment. In repetitive nerve stimulation study shows a decremental response in myasthenia gravis and incremental in Lambert-Eaton myasthenic syndrome. In CSF examination, albuminocytologic dissociation, which is the increased protein with the normal cell count and sugars, will be present in GBS. High protein levels with pleocytosis and normal or low sugars will be present in case of infectious diseases. The spirometry can be used to assess the vital capacity and the peak flow. Muscular nerve biopsy in selected cases of myopathy or neuropathy. So ICU management, airway protection, indications will be bulbar palsy, dysarthria, dysphonia, dysphagia, and poor gag reflex. Acute aspiration leading to respiratory arrest. Insidious aspiration, which is microaspiration, leading to pneumonia and gradual respiratory decompensation. So respiratory support will be required. Bedside test and the clinical assessment to determine the need for the respiratory support. ICU admission for vital capacity less than 1 liter or less than 50% of the predicted value. Respiratory rate more than 30. Unable to maintain a patent airway. Arterial blood gas, we have to monitor it regularly. Hypoxia and hypercarbia with the respiratory acidosis or late features of this neuromuscular disorders. May need assisted ventilation even with the normal blood gas in neuromuscular respiratory failure. Early tracheostomy for prolonged ventilatory support and physiotherapy should be encouraged.
How many of us have seen vital capacity in ICU? How many?
Spirometry.
You can do spirometry, but there are many other factors that comes in. It's not an easy thing to do in the ICU. But ideally we should do this. But it's difficult sometimes for the patient to really conduct that. So I would say it is a good thing
Bedside.
for quantitative thing, bedside thing, but it is sometimes difficult to do. That's why you see clinically we don't see it very widespread. Based on only vital capacity sometimes. Our main driven factors are EPG, our hemodynamics, SpO2, respiratory rate. Those functional aspects are becomes more important sometimes in these. Just based on vital capacity, it is very difficult to do also. But and routinely we don't do. But it is one of the important parameters on if you are thinking of GBS also, one of the classifying factors is vital capacity. We should do more and more, but it is a bit cumbersome.
So nutritional support should be encouraged. Enteral nutrition should be initiated as soon as the patient becomes hemodynamically stable. Nasogastric route is preferred. Precaution should be taken to prevent regurgitation, aspiration, or head end should be elevated. Prokinetics should be encouraged. Continuous feed through the enteral pump, and we have to check the residual volume. We have to start the nasojejunal feed in selected cases. Percutaneous endoscopic gastrostomy may be required if for a long-term use. Venous thromboembolism prevention. Immobilization is there will be immobilization. So deep venous thrombosis and pulmonary embolism risk is high. So low molecular weight heparin or unfractionated heparin, gradient compression stockings are useful. Passive leg exercises should be initiated. Then comes the pain control, acute and chronic pain. Opioid analgesics, anticonvulsants, and antidepressants may be used for the neuropathic kind of pains. So autonomic disturbances can are seen in GBS. Depending upon the symptoms, we have to treat the excessive secretions with the anticholinergics. If it is a disproportionate tachycardia, then beta blockers may be used, and if it is a symptomatic bradycardia, then we have to go for a cardiac pacing. Pressure source, frequent turning, and the pressure relieving mattresses should be used. Physiotherapy should be encouraged. It is important in early course of the disease and in rehab. Passive exercises, cough assist devices, and splints are useful. Management of specific illnesses. In critical illness neuropathy, history of some critical illness like sepsis, multi-organ failure, severe trauma or burns will be present. Clinical signs include generalized flaccid weakness, which usually worst in the proximal when compared to the distal muscles, and decreased deep tendon reflexes will be there. Extraocular muscles are relatively spared. Facial and bulbar muscles are usually involved but not always spared. Pain or paresthesia is not seen. Sensorium is intact. It presents as failure to wean from the ventilator. Investigations include nerve conduction velocity. There will be nerve conduction studies include decrease in the amplitude of the motor and the sensory action potential with the preserved conduction velocity, which denotes the axonal neuropathy. Electromyography will reveal fibrillations and decrease in the recruitment of the motor unit potential. CSF is almost always normal. It is diagnosed. It is a diagnosis of occlusion or other neuromuscular junction abnormalities. Treatment is supportive, intense glucose control, and early treatment of sepsis. Recovery is spontaneous in 3 to 6 months and is often partial. Prognosis depends upon the underlying illness. Critical illness myopathy, it is difficult to distinguish clinically from its neuropathic part, but both may occur concurrently. It occurs in patients with ARDS or severe asthma who have been treated with IV corticosteroids, aminoglycosides, or non-depolarizing neuromuscular blocking agents. Plasma creatinine levels are transiently and marginally elevated. Electromyography shows small amplitude, short duration, polyphasic motor unit potentials, and sensory nerve conduction studies will be normal. Repeated nerve conduction studies is done to exclude a defect of neuromuscular transmission caused by the defective clearance of the neuromuscular blocking agents. Treatment will be supportive care, cessation of steroids and drugs acting on the neuromuscular junction as rapidly as possible, tight glucose control, and early treatment of sepsis. Recovery is spontaneous in 3 to 6 months and is often partial. Prognosis depends upon the underlying illness. Many patients who survive critical illness experience prolonged impairment in cognitive mental health, known as post-intensive care syndrome. Neuromuscular weaknesses related to critical illness is often a significant aspect of the syndrome. Patients with critical illness myopathy tend to have a better outcome than those with critical illness polyneuropathy. Guillain-Barré syndrome.
The problem with CIP and CIP is that it is firstly the overdiagnosed entity. Many of the people who have read about it, you read about this without having knowledge of other syndromes, you will tend to overdiagnose it. Firstly, and secondly, what I see is that there is very reduced sensitization towards CIM and CIP. If you know that okay, these are the things that can result into CIM and CIP, then that is one aspect of it. If your patient, you have discharged them from the ICU after a responding dose, that doesn't mean that our duties are over. Whatever you are doing here will have the effect later on in their life. So many of them they suffer from PICS. Okay, PICS is one of the very important things that we should be aware of. These patients, when they go out from the ICU, either in the room or after discharge from the hospital, will face a lot of trouble in getting back to their normal lifestyle. They can have cognitive issues, they can have psychological issues, they can have weakness that never goes down. That weakness can persist for months to come. So it's very important whatever we intervene at this time, and these patients has to have a good, very good control. So CIP, CIM is overdiagnosed sometimes, and in the same way underdiagnosed. It doesn't mean that every patient will have a proper CIP, CIM. They might have very mild symptoms that are missed out, basically. That might go in the long run when they are discharged. It might have manifestation, and these patients will have difficulty in adjusting later. So nutritional care should always be practiced. You try doing that with few of your patients, you will see and follow it up. Very important is to follow up your patients. How many of you follow up your patients? Now, you won't follow, you won't learn. You should follow your sick patients. Then you really what is really happening with them. If you follow them, then you will be definitely there. That has changed my practice. I follow a lot of my patients, not from now, from years ago. That helps you to your intervention, what you are doing, you will get more sensitized if you start following them. Because if you see that okay, something has gone wrong after discharge, then your mind can really think that okay, something I can intervene here, do better now, so that the patient should not be suffering later on. That better now is good sugar control, stopping of the unnecessary drugs that we can always do, early mobilization of the patient, early respiratory physio of the patient, good nutrition of the patient. This is in your hands that you can always do. Okay? So this I feel you should all be sensitized towards. If you are doing this and then your CA incidences will really come down. Okay. Next.
So Guillain-Barré syndrome, there will be a history of acute GA or URTA 1 to 4 weeks before the onset of neurological symptoms, which is present in 70% of the cases. Campylobacter jejuni gastroenteritis is the most commonly identified precipitants. Predisposing factors like HIV infection, Hodgkin's disease, history of recent immunization, recent surgery, organ transplant, paresthesia in the legs, which is rapidly ascending weakness, which can progress up to a month. Symmetrical weakness in both the proximal and distal muscle groups will be present with the loss of attenuation or of deep tendon jerks. Sensory loss is mild. Bifacial and bulbar muscle involvement is present. Autonomic dysfunction and respiratory involvement may occur in the acute stage and may be fatal. Symptoms typically progress over a few weeks. If the peak is reached with the 24 hours or after 4 hours, 4 weeks of symptom onset, the alternative diagnosis must be considered. The investigations are usually normal in the first week of the illness. Diagnosis has to be based on history and clinical examination. CSF examination later reveals albuminocytological dissociation. Electrodiagnostic studies abnormalities of the F waves in the beginning with prolonged or absent F waves and absent H reflexes. Other features of demyelinations like prolonged distal latencies and decreased conduction velocities may also be present. Treatment will be IVIG 400 milligram per kg per day for 5 days. Uh, Next will be plasmapheresis 40 to 50 ml per kg per exchange. A total of 200 to 250 ml per kg in 3 to 5 exchanges over 7 to 14 days is recommended. Steroids are not recommended for GBS due to the lack of benefit and possible delay in recovery. Switching between IVIG and Flex is not recommended. Approximately 80% of the patient can walk independently and more than half recover completely in over 1 year.
So basic classification for GBS back. So basic classification, whenever you get GBS, the classical thing will be it is not very very acute. You have to have the symptomatology that is traced back to at least 2 weeks or 3 weeks. That is number one. Distinguish it whenever you see. Then after that, classically, symmetrical, but you may get non-classical. Sometimes GBS has many variants. Okay? I always say that described, undescribed variants are almost more than 55, 60 variants. But the known variants, most commonly that we deal with, most commonly will be AID that we get it. But then you can have motor varieties, MR, external variety, MR, and SAR. So you will have AIDP, MR, and SAR that you commonly see. Also commonly Guillain-Barré. MFS. Okay, these are the most common that we see. But apart from that, there can be there can be other variants in which you cannot classify them. Some of the symptoms will be matching GBS, some of the symptoms will not be matching GBS. In which the history becomes important and exclusion of other possibilities becomes important. So in that case, in those cases, once you have classified them, your NCS, your CSF, all those things will be coming into the picture. CSF is not a common thing. If GBS is a diagnosis and we have done it, basically after excluding everything. Always remember GBS will be a diagnosis of exclusion. Okay, I always say that GBS should not never be your number one diagnosis. When you are diagnosing GBS, you should always consider other possibilities, and then it is not matching, then it should be your GBS. So once it is done and CSF is classical, you barely require CSF. CSF you only require when you are not sure about it. Because some of the infections can look like GBS or doesn't like GBS, like lines. If you have your protein should be on the higher side. If you see a higher, what we call as WBCs in your CSF, that you should be cautious about. That is not classical GBS. So when you are confused, that if it is not completely matching, then okay, you are doing a CSF. In CSF, your classical presentation will be the proteins will be high. So any sort of inflammation, proteins will be high. So that is whatever you call it, immunopsychological dissociation or a high proteins is the classical of GBS. Okay. So, but if the WBCs are there, WBCs are not classical. So if you see there is a significant amount of WBCs, then you should reconsider your diagnosis. There can be infections like Lyme's, or there are other, I forgot actually, there are 2 or 3 of the Lyme's is one. There are other atypical infections that always be considering into the picture. So whenever you get a CSF, CSF will help you to discriminate between these two. So your management will matter because GBS partly will be immunomodulation, but if you get a higher WBCs, you have to evaluate for any underlying infections.
So, myasthenia gravis is an autoimmune disorder characterized with the muscle fatigue. The patient requires admission to ICU when there is an impending or full-blown myasthenic crisis. There will be dramatic worsening, particularly of respiratory symptoms and bulbar weakness. Predisposing factors are systemic infection, drugs that exacerbate myasthenia, surgery and anesthesia, tapering of immunotherapy. Drugs which exacerbates myasthenia are alpha interferon, quinolones, D-penicillamine, macrolides, botulinum toxin, beta blockers, neuromuscular blockers, calcium channel blockers, quinine, quinidine, procainamide, magnesium salts, aminoglycosides, iodinated contrast agents. So commonly begins with the fluctuating and asymmetric doses and weakness of extraocular muscles, followed by the weakness of bulbar, masticatory, and proximal limb weakness muscles. Respiratory muscle involvement indicates myasthenic crisis. Muscle bulk, tone, reflexes, and sensory examination are normal.
So fluctuating is the thing. Myasthenia, the major thing you should remember is fluctuating. It is not constant. If it is constant, it should not be, might not be myasthenia. And just that. So the important thing is this. So any drug which has neuromuscular LMJ toxicities, any drug or anything that you are giving which has LMJ toxicities will affect course of any LMJ disorder, particularly myasthenia. So you have to be cautious with this list. Also cautious with magnesium. Hypermagnesemia can be associated with LMJ disorders. As you have other toxins like we described, NMPs, steroids, antibiotics like maybe myopathy or anything like that, you have hypermagnesemia has been associated with that. So if your patient has been retaining a bit of magnesium on the higher side due to any other cause, you have to those can independently trigger. They are not primarily hypermagnesemia cannot be a primary function, but if there is some disorder, hypermagnesemia can be a trigger of that, and it will help the cause and it will lead to the diagnosis. So, if the magnesium levels, so very, very important whenever you send these, your baseline electrolytes should always be synchronized. Baseline electrolytes, calcium, magnesium, phosphate, potassium, sodium, then TSH levels, very, very important. Okay. And what I send extra is urine phosphate. That is one thing that is very, very rare. I managed only one case till now. Phosphate case. Only one chap. So after that, we changed our protocols in sending urine phosphate. They're very, very rare, but if symptomatology is matching and there is, you should send. Generally, we send two samples. One sample is negative, you send one more sample. So that is a classical of urine phosphate. So this completes the entire pattern of GBS. And also it helps in myasthenic disorders. Next.
So investigations will be serum anti-acetylcholine receptor antibodies are positive in more than 90% of the cases. Some seronegative patients will be having anti-muscle specific tyrosine kinase antibodies. So heterophonium test pre-treat with 0.5 milligram of atropine 2 milligram of hydrophonium given IV, and then incremental doses 3 milligram and 5 milligram intravenously. Observe at each dose for 1 to 3 minutes for an increase in the muscle strength. Electrodiagnostic tests revealed decremental response in CMAP on repetitive nerve stimulation test. Chest imaging should be done to rule out thymomos. Treatment: plasmapheresis 50 ml per kg per exchange, a total of 200 to 250 ml per kg in 5 to 6 exchanges over 7 to 14 days. This is for myasthenic crisis. Musk positive myasthenia tends to respond better to plasmapheresis than to IVIG. IVIG 400 mg per kg per day for 5 days, preferred over plasmapheresis in myasthenic crisis if severe infection coexists.
And the Musk, anti-Musk will also be, yeah, is written that anti-Musk will be more propensity towards moving to refractory GBS. So whenever you get non-classical symptoms of GBS, more of ophthalmoplegias and all that, sorry, whenever you are thinking of non-classical myasthenias, in which you are having more of bulbar and symptom presentations and you are classical looking like anti-Musk, antibody related, then those myasthenias you have to keep in mind, they are very highly prone for getting to the refractory zone. Refractory means they might not be very sensitive to plasmapheresis. You do plasmapheresis, they will improve to a certain extent, but again the patient, the symptomatology will continue. So initially when you are sending your antibodies, if you have a doubt, you should send anti-Musk also according to the initial symptomatology. You have to send both together so that you don't waste your time. You start your plex and then your say Musk comes positive. You should be very pro in giving rituximab. They will require second line long-standing immunomodulation. So these are the group of patients we give actively rituximab.
So steroids, prednisolone 1 milligram per kg per day. In about one third of the patient, myasthenic weakness worsens temporarily for 7 to 10 days after starting steroids. The patient may go into a crisis situation. Steroids can be gradually tapered once the symptoms are improved, although many clinicians continue a low maintenance dose of 5 to 10 milligram long term. Steroid sparing agents like azathioprine, cyclosporin, mycophenolate mofetil are generally started along with steroids as they take several months to show their effect. Musk positive myasthenia tends to respond better to rituximab rather than these agents. ACHE inhibitors, uh, pyridostigmine 60 mg oral, neostigmine 15 mg oral or 0.5 mg intravenously can be given. These should be discontinued if the patient is ventilated and should be reintroduced on weaning. Thymectomy is may be useful especially in young females, but the response is delayed. It is mandatory in thymomos. In 2020, the International Consensus Guidance for the Management of Myasthenia Gravis stated that thymectomy should be strongly considered in early non-thymomatous anti-acetylcholine receptor antibodies positive generalized myasthenia to improve the patient outcome. Anterior horn disease, the commonest will be amyotrophic lateral sclerosis. It is usually sporadic and slightly more common in males. Peak incidence will be between 65 to 74 years. Mean disease duration from onset to death is about 3 years. Muscle wasting and weakness are usually patchy. Fasciculations are prominent. Both upper and lower motor neuron signs are seen, and there is no sensory loss. Bulbar and respiratory muscles are involved in the later stages of the disease, and respiratory failure is usual mode of death. So far, there is no known drug that significantly prolongs the survival. Riluzole or IV edaravone may delay the need for ventilatory assistance by 2 to 3 months. So, IVIG in ICU, adverse reactions of IVIG will be immediate and delayed complications. Uh, Immediate will be infusion related reactions, most common, which is due to cytokine or complement mediated, anaphylaxis, aseptic meningitis, and TRALI. Delayed complications may be thromboembolism and aka hemolysis, hyponatremia, hyperviscosity syndrome. So ICU precautions before starting IVIG will be we have to see for a pre-infusion checklist, confirm the indication of the IVIG, baseline investigation should be sent. Now we have to risk stratify the patients, identify the high risk patients like CKD, CAD, previous history of thromboembolism, hypercoagulable states, IgA deficiency, elderly and hypovolemic patients. Product selection, the product should be low osmolality, non-sucrose containing IVIG in renal patients, low IgA content in case of IgA deficiency, adequate hydration should be given before the infusion, which is especially important in case of CKD, elderly patients, and sepsis. Special ICU consideration include in septic patients, you have to monitor for worsening hyperviscosity, watch for renal function closely. In neuromuscular crisis patients like GBS and myasthenia gravis, we have to monitor for forced vital capacity, early elective intubation if needed, watch for autonomic instability. In cardiac dysfunction, risk of fluid overload is present, therefore the infusion should be very slow. Monitor BNP if needed.
More important is that when you are getting these patients and you are classifying, say there is a provisional diagnosis of GBS or myasthenia, very, very important when you receive from our analysis that you classify them closely with these patients. We always say that you should stick to any one of the scoring systems. Whenever you get these patients, you stick to any one of the scoring systems which helps you place focus on these patients. So a person who is coming with a respiratory distress, if we don't know what variant we are dealing with, we will exactly not know whether this patient will require a ventilator or not, or what is the risk of this patient going into the ventilation. If this patient is going on ventilation, what are the scoring systems that tells me whether he will be out or he will need a tracheostomy? Then if it is out or he needs tracheostomy, then whether he is going to go back and live his normal life. So there are scoring systems for each of these variants, particularly in GBS. There are very good scoring systems in Myasthenia. So the acute scoring system that is concerning to us, we should always be doing that because that helps you to early classify and prognosticate these patients when you're talking to the attendants as well. How would you classify? All Myasthenias are not the same. All GBS are not the same. Okay, so GPS with massive dysautonomia at the time of presentation will have a poor prognosis compared to a simple AIDP who will do very well, who might do very well just when you just start a course of immunoglobulins by second, third day, you might be out of that. Versus a patient who is having a MMR insan variety along with a dysautonomia, they do very, very bad. So you have to classify. This is how you classify, and then you put them in a scoring system, and that tells you a probability that this patient is going to deteriorate, this patient is going to improve overall. So every one of you, I think, have a habit of just learning one or two scoring systems whenever you get these type of disorders. Okay.
So infusion protocol in ICU setting will be we have to start the infusion very slowly at zero point 0.3 to 0.5 ml per kg per hour. We have to gradually escalate every 30 minutes and we have to continuously monitor the vitals. Avoid rapid infusion in case of cardiac dysfunction, renal impairment. So management of complication, infusion reaction, we have to stop the infusion temporarily. We have to give PCM, antihistamines, steroids if there is any moderate reaction. Restart at lower rate once if the patient is stable. Anaphylaxis, immediate ICU protocol should be initiated. You have to stop the IVIG. Intramuscular adrenaline 0.5 milligram, 1 is to 1000 dilution. Airway management should be seen. Oxygen should be supplemented. IV fluids, IV steroids, nebulized bronchodilators, and do not restart IVIG. So the other complication will be AKI. We have to stop the IVIG, optimize the hemodynamics, maintain a mean arterial pressure of more than 65 mmHg. Sir, okay, sir. So yeah, how to prevent all these reactions? The slow infusion rate, adequate hydration before the infusion, avoid sucrose formulation in CKD.
Anybody has seen ADHD associated anaphylaxis? Anyone? You've seen? It's not. So, see, over a period of time, see, IVIG are immunoglobulins. Any proteins, external proteins going into the body will induce changes. That is one. Second, also, you should remember that not only due to the proteins, many of the reactions happen because of the carrier molecules. So, what is carrying those proteins? So, the base, so over a period of time, if you see, IVIGs have become more safer day by day. The carrier molecules have become better. In CKD patients, also, you can use it now. The effect on the kidney have become better because of the carrier molecules, mannitol, sucrose, non-sucrose containing. There are many bases that are changing. There are many varieties of IVIG now available, starting from 5%, 10%, 20%. Then you have the carrier molecules. You have 4 to 5 varieties. So IVIG is not single always. It is there is a spectrum of IVIG that is available now. So you can choose according to which will benefit your patient more. If the patient is, you require a low volume, definitely you can just go for pretty grams as you have 50% and you have 10%, you have 5%. So you can choose from a lot. So it just becomes safer because we definitely over the period of time, the brand has defined the mechanisms in which it is collected and purified has become much better. So reactions have come down, but we do see reactions. So that's why these come in these topics.
Plasmapheresis, therapeutic plasma exchange is an extracorporeal blood purification technique where the plasma is removed and replaced with albumin, FFP, and crystalloids to eliminate pathogenic substances. It removes autoantibodies, immune complexes, cryoglobulins, paraproteins, cytokines, toxins. So prerequisites before starting a plasma exchange will be confirm the indication and the timing. Is it category 1 based indication? Is the disease antibody mediated? Is it adjunct to an immunosuppression? Early initiation improves outcomes. Example TTP and GBS. Rule out the following things before starting. So platelet should be more than 20,000. INR, PT, and ABTT should be normalized. Fibrinogen, we have to make sure that it is more than 100 milligram per deciliter. Serum calcium, electrolytes, and other parameters should be in the normal range. Relative contraindications will be severe hemodynamic instability, uncontrolled sepsis, severe hypocalcemia if there is no vascular access, severe coagulopathy without correction. How much a plasma volume should be exchanged? Plasma volume is calculated by 0.07 into weight in kilogram into 1 minus hematocrit. Usually, the exchange should be 1 to 1.5 times volume. Plasma volumes per session should be exchanged. Vascular access, preferably W. So, precautions, yeah, citrate toxicity, which is the most common complication. Citrate binds to the calcium, lead to hypocalcemia. So, prevention by initially we have to start the plex with the slow infusion rate. Prophylactically, calcium gluconate should be given. Coagulopathy risks will be there. Albumin removes the clotting factors. Monitor fibrinogen every 2 to 3 sessions. Replace with FFP fibrinogen is less than 100 milligram per deciliter. And infection prevention, strict asepsis, and remove the catheter as soon as possible if the session is over. So complication will be hypotension, which is the most common complication, citrate toxicity, bleeding, anaphylaxis, which is also more common with FFP, arrhythmias, hemolysis, and thrombosis. So daily IC monitoring during the course should be neurological examination in case of GBS and myasthenia. Platelets should be monitored. LDH, renal function, fibrinogen every 48 hours. Daily electrolytes, hemodynamics. So when to stop therapeutic plasma exchange? When there is a clinical improvement, target antibody is reduced, platelet recovery when it is present, no further benefit after adequate session. Complications when the complications outweigh the benefit. Rituximab is a chimeric monoclonal antibody against CD20 on B lymphocytes, causing B cell depletions. Indications will be severe autoimmune disease like granulomatosis with polyangiitis, microscopic polyangiitis, SLE, immune thrombocytopenia, autoimmune hemolytic anemia, myasthenia gravis, pemphigus vulgaris, hematological malignancies like non-Hodgkin lymphoma, chronic lymphocytic leukemia. So prerequisites will be we have to screen for the infection screening, uh, baseline routine, clinical assessment, and dose regimens will be in a case of hematology if there is any lymphoma 375 milligram per liter square IV weekly for 4 doses. Autoimmune diseases 1 gram IV on day 1 and on day 15. Infusion protocol we have to start at 50 milligram per hour, then increase every 30 minutes by 50 milligram per hour, maximum 400 milligram per hour if tolerated. We have to pre-medicate the patient 30 to 60 minutes before infusion. The infusion reactions will be fever, chills, hypotension, mild bronchospasm. In case of severe reactions, anaphylaxis, shock, ARDS. Serious complications beyond the infusion reactions are tumor lysis syndrome, HBV reactivation, progressive multifocal leukoencephalopathy, bacterial sepsis, pneumocystis jirovecii, pneumonia.
Rituximab now has a lot of targeted therapies getting involved, but all of them pipeline. So we might get in the near future a lot of good targeted therapies for these specific disorders. Particularly in DBS, there is already one available. We don't use it much because it has not shown immediate benefits. Infliximab is one of the doesn't have an immediate benefit to the patient, but the few studies are there which tells that it has a long-term benefit compared to a patient which is treated with, say, anti-aging. But that is the reason we don't use it. Rituximab is one of the things that is available. There are details, three or four targeted therapies are already there. The problem is that only two or one is claimed to be used commonly. Other three are all under research, and availability is a big thing, cost is a big thing.
So in special ICU scenarios, rituximab in myasthenic crisis can be used in the refractory cases. Rituximab in severe immune thrombocytopenic purpura with bleeding can be used. So to summarize, so if a patient presenting with suspected neuromuscular weakness or respiratory failure in ICU, you have to first look for if there is any respiratory compromise. So the forced vital capacity should be seen, the spirometry, or a simple bedside assessment like single breath count can be seen. If it is less than 20, then it strongly indicates the patient is in impending respiratory failure. So we have to first we have to do the immediate stabilization. ABC should be assessed. First, we have to try with NAV. If there is no bulbar weakness or excessive secretions are present, then we have to go for an invasive mechanical ventilation in case of severe GBS. Uh, Step one will be then following that we have to assess the history wise. Anterior hornsel disorder, patient will be telling a typical history of weakness starting in one limb and slow spread to the others, muscle twitching which is fasciculations, muscle wasting, and difficulty in speaking, swallowing, choking, and change in the voice which is indicates the bulbar weakness. Numbness or tingling sensation will not be present, and breathing difficulty we have to suspect if there is any motor involvement of the phrenic nerve. Uh, in case of peripheral nerve diseases, patient will be complaining of mostly of weakness which is spreading from the feet and ascending upwards from the distal to the proximal. Numbness, tingling, or burning sensation will be present like paresthesia or burning sensation. Imbalance while walking in the dark, which indicates large fiber neuropathy or loss of proprioception. Recent fever, infection, or diarrhea, uh, palpitation, sweating, or BP fluctuations, case of, which represent the dysautonomia. So, difficulty in buttoning, mixing food, and easily dropping objects. So, distal weakness. Uh, in root or plexus lesions, patient will be complaining typically of pain, shooting pain in the from the neck or back to the arm or leg, uh, and weakness limited to one limb, which is indicating the radiculopathy, and numbness in the particular strip of the skin, dermatomal sensory loss, and weakness after sudden movement or heavy lift or trauma, which indicates a disc prolapse. In case of neuromuscular junction disorders, in history, there will be typical history of fatigability indicating patient in his own words complaints of weakness worsening as the day progresses or by work, drooping of eyelid, double vision when the extraocular muscles are involved, and rest whether the resting improves the weakness, difficulty in chewing or swallowing at the end of the meals, and any malignancy history running in the family. In case of myopathies, patient will be complaining typically of difficulty in climbing the stairs and getting up from the chair, uh, difficulty in combing the hair, muscle pain or tenderness, any dark urine indicating myoglobinuria, and any family history of any genetic disorders. So examination wise, in case of anterior hornsel disease, there will be hyperreflexia when it is coexists as upper motor neuron lesions. Usually, the reflexes will be absent or areflexia, asymmetrical muscle weakness, which starts distally, and the tone will be flaccid. In case of peripheral nerve diseases, and the weakness will be more in distal than compared to the proximal. Areflexia will be there, and typically Glovin stalk neuropathy will be present as distal axons are first affected. It starts from the feet, the legs, and it ascends to the hands. Um, then autonomic signs should be assessed. There will be palpitations or a wide range of BP fluctuations and sweating. In case of root plexus lesion, there will be radicular pain, dermatomal sensory loss, myotomal weakness, and reflexes will be lost like a knee jerk and ankle jerk. Straight leg raise test causes stretching of the compressed nerve root, which produces pain. In terms of neuromuscular junction disorders, there will be sustained upward gaze can cause a increase in the doses. Sir, okay, sir.
The students say whatever people learn, they are getting more confused now. Because last time
Okay.
it was good, the flow was good.
Sir, we have to assess pre-existing neuromuscular diseases which causing eye shot. Same thing, sir. Sir, electrophysiology studies, nerve conduction studies, repetitive nerve stimulation test. Sir, actually, sir, first when the patient,
One electrophysiology session we have.
this
These two
one,
combined together, before science, what we have.